Welcome to the Outperform Cancer podcast, where we identify anti-cancer strategies found in peer-reviewed scientific research. My name is Mary Beth Gilliam, and I'm a metastatic breast cancer patient searching for ways to outperform cancer. In each episode, we talk to a well-regarded, published researcher who's focused their work on a potential anti-cancer strategy that could be used with conventional treatment. Visit the Outperform Cancer website at outperformcancer.com to find other anti-cancer strategies and to sign up for our newsletter. In my earlier podcast with oncoproteomics specialist Dr. Connie Jimenez, we discussed high-dose intravenous vitamin C on a micro level. Today, we're taking a macro view. Professor Dr. Joseph Cullen will discuss his Phase 1 and Phase 2 clinical trials where he uses standard care therapies with one addition, high-dose intravenous vitamin C. With this simple, relatively low-cost additional therapy, he's achieving some outstanding results. Listen to this.
But when you added ascorbate, we doubled their overall survival, and we have 3 patients who are still alive 7 years later.
Okay, wait a minute. Are we still talking about pancreatic cancer?
Yeah.
Dr. Cullen is a professor of surgery at the University of Iowa Carver College of Medicine with a secondary appointment in the Department of Radiation Oncology. He completed his medical degree and residency at the University of Iowa before finishing a postdoctoral fellowship at the Mayo Clinic. Join us now as we learn how Dr. Cullen and his colleagues are extending the lives of people with some of the most hard-to-treat cancers, including pancreatic, glioblastoma, rectal, and non-small cell lung.
So thank you for coming today, Dr. Cullen. We really appreciate your time, and we're so interested in what you have to share with us.
Thanks for having me.
Can you talk a little bit about your most recent work? I know in the past 2 years, you've had no less than 14 different research articles published in very high impact medical journals about high dose vitamin C, or IVC, as we'll call it, also known as ascorbate, in case someone is looking up those studies, and its impact on cancer. You've also led 8 clinical trials utilizing IVC, including 2 Phase 2 trials, and then your organization, the University of Iowa, has led a total of 16 clinical trials in this area. That is an incredible amount of work. And I know that the list wouldn't be this long if you weren't seeing some very exciting results.
Yeah.
So if you could start us off with the bottom line, based on your experience and your research, is high-dose IVC an important anti-cancer strategy?
Well, we think it's going to be, and we're progressing in a very systematic way, mechanistic-based. A lot of these complementary and alternative medicine practices are not really rooted in fundamental mechanisms. But the good thing about this one, about IV vitamin C, we do have mechanisms. We know how it's killing the cancer cells. And it's killing it because it generates hydrogen peroxide. And the cells then die of the overdose of, or overwhelming amount of hydrogen peroxide. So we know the mechanisms, and we've done this in petri dishes. We've done it in mice, and then we've done Phase 1 trials in humans to seeing if it's tolerated. Because if it's not tolerated, you can give a lot of things that kill cancer, but if they kill the patient, it's no good.
Yeah.
So we know it is tolerated very well, and the big difference, as we've discussed before, is the difference between oral vitamin C and IV vitamin C. And oral vitamin C, you can give, you can take like 500 milligrams 4 times a day orally, and you get micromolar levels in your blood, just micromolar. But when we give it IV, we bypass the mechanisms that the body has to eliminate the excess vitamin C. We bypass those, and we get millimolar levels. In our most recent study, we increased the levels of vitamin C in the blood in the serum in patients by 500-fold.
Oh, wow.
Yeah.
Yeah. And that difference then from a micromolar to a millimolar, it's exponential.
Right. Yeah. And so at millimolar levels, the vitamin C doesn't act like an antioxidant, which people claim, and it does at low levels, but it acts as a pro-oxidant. So it actually makes hydrogen peroxide and kills the cancer cells. And the one of the best things about this, I think, is that it doesn't harm normal cells. For the normal cells in your body, non-cancerous cells, have mechanisms to remove this hydrogen peroxide, and the tumors don't. So that's one of the real beauties of this.
So that's really interesting. Do the cancer cells then have some sort of common mutation that allows it, that prevents it from getting rid of the hydrogen peroxide, whereas a normal cell doesn't? Or what is the difference?
We're not quite sure yet.
Okay.
We're looking at it in some of our studies. It looks like catalase, the enzyme that converts hydrogen peroxide to water and oxygen, is very low in tumor cells. Mm-hmm. And so therefore they can't metabolize the hydrogen peroxide. Mm-hmm. But we've made resistant, ascorbate resistant cell lines, and there's different mechanisms involved. And so that's one of our main areas of investigation now, is to determine what is turned on and what is turned off when these cells become resistant.
That's super interesting. Does the catalase that you were referring to that's low in the tumor cells, does that have anything to do with hypoxia, which I know is common in tumor cells?
It might. We've shown, though, that the ascorbate works in normal oxygen tension, reduced oxygen tension, and then very reduced oxygen tension. So it works in all those situations. Now, one hypothesis is that tumor cells, the extracellular fluid space, has no catalase at all. And so the ascorbate may work in generating more peroxide in those extracellular spaces of tumors, where in normal cells, they have plenty of catalase to take care of things.
Interesting. Yeah. You know, what my mind goes to when you say that it works in even in these high and low oxygen environments is that, so even patients that might be in a highly hypoxic tumor microenvironments, which usually is a very bad sign for the patient, that this might still be a beneficial strategy for them, even though it is a very hypoxic cell environment. Am I connecting the dots?
Yeah,
accurately.
Yeah, I think that's accurate. You know, one of the most hypoxic environments is pancreatic cancer, and our best studies with ascorbate are on pancreatic cancer. So there's some, I would say, maybe anecdotal evidence that that's the truth. That's the case. Yeah. We're still looking into it. Yeah.
Very interesting. Well, you mentioned this study that you have done, this clinical trial with pancreatic cancer patients. Can you talk a little bit more about this? Because you've had a phase 1 trial with pancreatic cancer patients, and I believe this was treatment, standard of care treatment plus high dose IVC, correct?
Right.
And now it moved to a phase 2. So there must have been some good results. Can you talk a little bit about that journey that you had, that research journey that you had, and what happened? You know, what led you to that first study? What were the results? And then what transitioned onto this phase 2?
Well, yeah, that's a great story. The investigator who determined that IV ascorbate is much different than oral ascorbate came and gave a talk at Iowa. And his name is Mark Levine. He works at NIH. And I saw that and I thought this makes sense. Let's try it. So we tried it and we got really good results in our in vitro and in vivo models. So we presented it to one of our medical oncologists, Dan Berg, and he said, yeah, let's give it a try. And he really stuck his neck out. Because a lot of the medical oncologists said, no, we're not going to do this. This is crazy. It's been around forever. It doesn't work. It's crazy.
Mm-hmm.
So we tried it. And in the 9 patients who could tolerate 2 cycles of it, we increased their overall survival from 6 months to 16 months. Now, that was a small trial. This is in stage 4 pancreatic cancer, where the median survival is about 6 to 8 months.
Wow.
So we doubled it. But that was a small trial. And what came out of that trial was it was well tolerated, very, very few side effects. And we were able to get doses and get an idea of where we are with doses and how much to give.
So what were the doses, if you don't mind me interrupting?
Yeah. So what we did in that trial, we did a dose escalation trial. We wanted to get at least 20 millimolar in the serum after the infusions. So what we would start with is 50 grams of IV ascorbate twice a week, and we would draw their blood right after the infusions. And then if it didn't get to the 20 millimolar, we went up to 75. And then if it didn't get there, we went up to 100. And wherever we got to over 20 millimolar, we stopped. And in one patient, kind of a big patient, we had to go up to 125 grams, which is,
a lot.
A lot, yeah. And it just takes a long time. But it seemed to work well, and the patients tolerated it.
Mm-hmm.
And then we did another phase 1 trial where, in patients with pancreatic cancer, if they have to have a radiation, we combine it with radiation. And in that trial, we did a cohort of 50 grams, 75 grams, and 100 grams. And we found out that the 75 and 100 grams actually got about the same amount in the blood. So we went with 75 grams 3 times a day in our phase 2 trial, which has just ended.
3 times a day or 3 times a week?
3 times a week. I'm sorry.
Okay.
Yeah.
All right.
3 times a week, which the trial has just ended, and we're in the process of getting out to submit it for a paper.
And so just to clarify, that was in conjunction with radiation, you said?
Yes. Yeah. And those results in that, even though it was a phase 1 trial, we looked at the patients at the University of Iowa who, for some reason or another, didn't want to do the ascorbate, and they just wanted to do the radiation.
Okay.
And then we looked at historical controls, and the historical controls were similar to the patients who didn't want the ascorbate.
Okay.
But when you added ascorbate, we doubled their overall survival, and we have 3 patients who are still alive 7 years later.
Okay, wait a minute. Are we still talking about pancreatic cancer?
Yeah.
Pancreatic cancer, stage 4.
No, these are locally advanced. Well,
okay.
I'm not sure what their stage was to begin with.
Okay.
But here's what happened. They come with pancreatic cancer. They have a large tumor. It's not resectable. They can't operate on it.
Okay.
So they told her, they talked to medical oncologists and radiation oncologists. They give them chemo and radiotherapy to decrease the tumor size.
Mm-hmm.
And in those patients, we added ascorbate.
Okay.
In 3 of the patients, the tumor shrank significantly that they could have the operation.
Okay.
When they underwent the operation, the pathologist saw no viable tumor cells in the past specimen.
Wow.
And in those patients, they're still alive. Those 3 patients are still alive.
Wow. So it was if I'm going to just recap. So for those patients who they originally came to the hospital, it was a non-resectable, meaning they were not able to do surgery at that time.
Right.
And so they gave them chemo, they gave them radiation, shrank the tumors, chemo, radiation plus ascorbate or IVC.
Yeah.
Shrank the tumors, but when they went in to remove them and they removed those cells, when they looked at the cells, they didn't even see kind of active cancer cells.
Right. No viable tumor cells.
No viable tumor cells. It's incredible. And so those 3 patients that actually went through that process, then they're live. They're still here.
They're still alive, yeah.
And how much time has passed?
It's been 7 years.
Wow.
Yeah.
And do you have any idea, like, for pancreatic cancer, even if it's not stage 4, the survival rate usually is?
Yeah. It's about 12 months.
So even if it's not stage 4, it's still only like maybe a year. It's still
Right.
a terrible prognosis.
Yeah. Even with a successful operation, yeah, it's still poor.
Wow. So those 3 patients have to be big fans of
Yeah.
the study.
In fact, one of them, it's pretty interesting. One of them was a new nurse supervisor when I was a resident.
Really?
And yeah, and just a lovely person.
Wow.
Hardworking. She always worked third shift in the hospital. She was a supervisor, so that goes along with a bunch of headaches.
Mm-hmm.
And it's just so cool to see her.
So cool to see. Yeah, I don't know. I love those stories, and I think they're really important for giving everyone hope. So that was that study we just discussed is a phase 1 study as well.
Right.
And that was different because it was, with the radiation. So what about the first study that we talked about? Did that study go on to be a phase 2?
Yeah.
So the first study we talked about was with I think it was 9 patients.
It was actually with more than that, but
Okay.
But our I think we had like 14 or so.
Uh-huh.
Some patients didn't tolerate anything right away.
Uh-huh.
But it gave us an idea that we could do this in safe and tolerable. The second study with the radiation gave us an idea to do a phase 2 trial looking at 75 grams 3 times a week for stage 4 pancreatic cancer patients. And that's the one that just finished.
Okay. And I know that is being submitted to a publisher as well, correct?
Yes.
And is there anything that you can tell us about that study? Maybe in general, I know that you can't provide specifics, but in general, did that further your initial work? Like, did you continue to see positive change?
Yeah, so a couple of things take away from this paper is I don't know if we were smart or dumb, but we put in an interim analysis.
Okay.
Because you don't want to, if you got to enroll a bunch of patients and halfway through it doesn't look like it's going to be successful, you don't want to, have the other patients suffer and do something that's not going to be successful. On the other hand, if it's very successful, ethically you have to stop the trial.
Mm-hmm.
Right?
Stop it and then provide it to everyone. Is that what you're saying? Yeah.
Provide it or do something else. Yeah. So we did the results, and with our statistician, we stopped the trial, and the results look very promising. And the second thing I would say is that if you look at side effects of chemotherapy, so we had 2 groups. We had the chemotherapy group, and then we had the chemotherapy plus ascorbate group. If you look at the chemotherapy group, the ascorbate group seemed to tolerate the chemotherapy better and for longer periods of time. So one would argue, well, they're tolerating the chemotherapy better and they're tolerating it for a longer period of time. So maybe that's contributing to an increase in overall survival.
Mm-hmm.
And what I would say is, maybe.
Yeah.
Great.
Yeah.
So,
whatever it is, it's working, right?
Yeah. Right. Yeah. That's great.
So just to recap, you actually stopped the study early because the results were so good.
Yes.
Okay.
Yeah. Ethically, we couldn't keep going.
So, and did everyone...
You can't offer, you can't offer somebody, okay, we have 2 arms of a trial. We know the one arm works really well, but, it's randomized. So unfortunately you go on the other arm. You can't do that ethically. I don't think I can.
Well, yeah, I'm so glad that you say that, right? As a patient myself, I'm so glad you say that. So does that mean that everyone in the study ultimately did start receiving ascorbate?
Well, no, because when we when we did the interim analysis, we had a couple of patients who were getting standard of care. And at that time, we only had a couple patients still on the trial. And for one reason or another, they didn't want to go. So
so it
we
was
offered it to them.
Patient choice.
Yeah.
Okay.
Yeah.
Right. And then the patients who had been on ascorbate, did they continue on it?
Yeah, they're done because they've all passed away. So, and that's the problem with stage 4. You have metastatic disease in the liver or whatever, lungs.
Mm-hmm.
But we did have one patient who survived over 2.5 years.
Okay.
With stage 4 pancreatic cancer. In fact, we had to give her chemotherapy breaks, which was unheard of. I mean, nobody had ever received this much chemotherapy in a year and a half, so we gave her a break, like a month or so.
Yeah.
Nobody had ever received this much chemotherapy for this long a time.
Wow.
Yeah.
And so this was the woman who lived 2.5 years was in the test arm of the study with the pancreatic cancer, stage 4 pancreatic cancer patients. And she was the one then, I'm assuming, that lived the longest?
Yeah, she did. And she was receiving ascorbate all the way up.
All the way up. And at any time, did the patients see any resolution to the tumors, or did they just stop growing as fast, or what was the progression?
Yeah. In some patients, you look at their scans. I have a couple of scans. I could show you where the tumor does shrink pretty significantly, and then it just kind of stays there for a while. In the other kind of experience we have, they'll have metastatic disease, but it'll all be stable, and it'll go on for a long time. There's also anecdotal reports. I know of a patient on the East Coast who was a pharmacist who gave himself IV ascorbic acid for his pancreatic tumor, and that's all he got. And he lived over 4.5 years. And he actually died of a complication related to an endoscopy, not due to the tumor. And in his scans and stuff, he had metastatic disease. And after receiving this for 4.5 years, the metastatic disease went away and the tumor shrunk. It was still there, but it just didn't grow.
Wow. So there's these kind of case studies that pop up. It sounds like that you've been reading or seeing where there are some interesting outliers or results based on people kind of taking things maybe into their own hands.
Yeah. But the good thing about our most recent trial is we did a randomized controlled trial, and the patients were randomized. And if you look at their disease, they're all the same. So, I mean, this is, as far as vitamin C, this is the first randomized trial of IV vitamin C that's ever been done. So,
wow. And in some prior podcasts that I've done, we've talked about the kind of the triad of research where epidemiology studies where we're looking at observing populations, and in vitro, in vivo studies where we're looking at petri dish and mouse studies, and then clinical trials. And that together, when you look at the results and you see you see consistency in results across those studies, that's when you really go step back and say, wow, it's hard to deny there's something here. Do you feel in your experience, I know you've done some in vivo, in vitro studies as well. Do you feel like we're getting alignment?
I would say the two arms of it, yes. The epidemiology arm, I'm not sure because, people just don't give themselves IV vitamin C.
Right.
Right. And we know that's the effective way to give it.
Right.
But yeah, I think this is going to, I think it's only going to get more utilized.
And what about some of the other studies at University of Iowa? I know that you have colleagues doing work in this area as well for, I believe it's non-small lung and colorectal cancer. What are their results looking like?
Well, the other one that's progressed nicely is glioblastoma or brain cancer.
Okay.
And we showed in a phase 2 trial that wasn't randomized that it increased overall survival too.
By double in that same range of
no, by months.
by
I think
months?
like I think it was like 5 to 6 months.
Mm-hmm.
But when your overall survival is only a year and a half, 5 to 6 months is pretty significant.
Yeah. And I know that, I mean, just from watching research presentations of lots of drugs from drug companies, sometimes as a patient, I'm looking at these results and they're like, we extended life by 3 months. And
Yeah.
I'll be like, hard to be jumping up and down about that. But
Right.
one of the things I've heard them say is, it's not just the 3 months. It's the fact that we have a mechanism for extending life that we know works. And so now we can try to help it work better, that we're on to something. And so, okay, that made me feel better about the results that they were providing. So with the glioblastoma, it may be 5 to 6 months, but as you were saying, that's a significant increase in time relative to the total time those patients usually have.
Right.
And perhaps it's a way to look forward and do more research of, what else can we do to continue to extend?
Yeah. And I think, you touched on something really important. In some of these trials, like for pancreatic cancer, a number of years ago, it was 2016, they did FOLFIRINOX, and they showed this great, compared to gemcitabine, and they showed this increase in overall survival from like 8 months to either 11 or 14 months, something like that. I don't remember that. Mm-hmm. But the problem was 40% of the patients couldn't tolerate the FOLFIRINOX. They couldn't continue with it. It was so toxic. Mm-hmm. And it goes back to something we mentioned earlier in the podcast. You can kill cancer cells, but if you kill a patient, what good is that?
Right.
So I always like to look. I always like to look at if they have done quality of life parameters with these studies to see if, the patients do pretty well with it, or it's very toxic. I think you got to put it all together.
You do. I mean, on my website, I say, okay, here's an anti-cancer strategy that also makes you feel better. Because a lot of the quality of life metrics I've seen with IVC have been, positive, not negative. And so it's like, wow, something that's killing cancer cells and makes you feel better. I mean, that's kind of nirvana, right?
Yeah, right. Exactly. Yeah.
So you were saying about glioblastoma, that it extended life with glioblastoma. And what about other cancers? Are you doing research in other cancers as well?
Well, we have an ongoing phase 2 on lung cancer. The results there, we haven't broken the results yet. Mm-hmm. We still have a few patients to enroll.
Okay.
Rectal cancer, we're looking at that. Not only looking at tumor characteristics, but also in rectal cancer, radiation is given during these, and we're looking at radiation-induced damage to normal tissue. And we think ascorbate, IV vitamin C, protects normal tissue from radiation damage. It radiosensitizes the tumor, but radio protects the normal tissue, which is kind of a big deal when patients get pelvic radiation for rectal cancer, prostate cancer, cervical cancer. The morbidity surrounding those type of treatments are significant. And so we think that maybe this can prevent some of those normal tissue toxicities.
Wow. Yeah, that's incredible. That is incredible. So lung and colorectal and glioblastoma, it seems like you took on all of the heavies.
Yeah. Well, I guess if you're going to make a difference, you better doing something that's really bad.
Yeah, right. The reason I started this podcast and website was because I felt like, as I did research on what are people doing research on, and what is happening, and what I found was, there are reasons for hope. And there are things that people are researching out there that that may help people that have cancers with really bad prognoses. And I feel like, there's always something else you can try. And with these clinical trials that are coming forward, particularly the ones you're doing, that's pretty exciting. And I would love to connect patients. You said you still have a couple openings in your phase 2 lung cancer trial.
Correct. Mm-hmm.
So we'll have links to that information for any listeners so that they could investigate the trial and just see if they might be a good candidate.
Yeah, and it's on clinicaltrials.gov too. They're all listed on there. So those are kind of good initial things to look at to see if you would qualify.
Right. Yeah, that is terrific. In your work, you talked about the IVC with radiation, and I have read in some things that you've written that you think IVC is both a chemosensitizer and a radiation sensitizer. I'm wondering if you can talk about what that means and how that affects a patient's treatment.
Sure. So briefly, when you give radiation, you generate these reactive oxygen species that kill the tumor cells. And when you give ascorbate, you produce hydrogen peroxide, which goes on to generate hydroxyl radical, which is another reactive oxygen species that kills the cancer cells. So they're probably synergistic because they work through a similar mechanism in generating reactive oxygen species. When you give chemotherapy, you induce DNA damage. And we've shown quite nicely that ascorbate alone at high doses induces DNA damage. And so then it's synergistic with chemotherapy too.
The ascorbate that minimizes DNA damage, is that what you're saying?
No, I think it causes DNA damage in the tumors.
Oh, in the tumor cells specifically. Yeah. And then that DNA damage of the tumor cells creates the cancer cells or the tumor cells to die off.
Correct. Mm-hmm. Yeah, they can't replicate, they can't divide. Yeah.
Interesting. So I've heard that some patients are even able to have lower doses of chemotherapy when given with ascorbate because it is a chemosensitizer. Have you seen any of that research, or do you have a comment on that?
I haven't seen any of that. Patients can have dose escalation or dose decrease due to, if they're not tolerating chemotherapy. In our randomized trial, it looks like that dose decrease didn't happen in the ascorbate group, so they actually got more chemotherapy. But there are some people who I've seen in the past who have proposed that we give a lower dose of chemotherapy along with ascorbate, kind of what you're saying. But you have to be really careful with that because usually institutional human subjects boards don't like that sort of thing.
Right.
Because the standard of care is to give chemotherapy at an X dose. Mm-hmm. And they don't want you to start fooling with that and giving it a lower dose when that's the standard of care. So what we've done is always added ascorbate to the standard of care. Mm-hmm. So you got to be careful with those studies, I think.
Yeah, it definitely it's experimental, right? It gets dicey because we what we do know is the dose of the chemotherapy that works, and that is the standard of care. Yeah. So yeah, it does seem like the path of least resistance right now, anyway, is just add the ascorbate and see what benefit.
Yeah.
See what benefit there is. Are there other ways to increase the sensitization? Meaning, I did read something about combining it with fasting or a fasting mimicking diet. Does that seem to make the ascorbate work better or enhance it?
Theoretically, I would say yes, because they work through they work with similar mechanisms. So fasting causes an increase in reactive oxygen species because there's lower glucose, and the lower glucose detoxifies these reactive oxygen species through a number of different pathways. So if you fast, you have an increase in reactive oxygen species. And with ascorbate, we know we increase reactive oxygen species. So they should be additive or synergistic. we haven't combined those two. One of my colleagues has done a nice study with fasting and a ketogenic diet, and he showed some nice changes in patients who had fasting and went into ketosis.
Mm-hmm.
We've never combined it with ascorbate, but that would definitely be a way you could go.
That would be a new next study, I think.
There you go. Yeah.
I understand that, with any medication, even aspirin, no two people respond exactly the same. With chemotherapy, some patients might get a complete resolution of the tumors for at least a certain period of time. Other people, the tumors might be resistant to the chemotherapy. So we're all kind of unique in our own ways. And what I'm wondering is, in your experience with your studies, do you see a lot of variance in how people respond to the ascorbate? Do some do remarkably well and others not so much? Or do you see pretty consistent benefit?
It's really funny. We see, I've given you a couple examples of patients who've done really well, the 3 patients that are still alive 7 years later. The one lady who had stage 4 pancreatic cancer lived over 2.5 years. We have seen some patients who probably had too extensive disease to really benefit from it, but we'd have to do many more patients to really see if there's a difference there. But then we've seen some patients who they received vitamin C for like a month and a half, and for some reason, and then they were taken off of it for some reason, and they've done really, really well. So, and they don't get it. So, they don't get any more vitamin C. So, it's kind of, there's a lot of questions out there about why this is working the way it is.
That's interesting. Is there a difference, or do we need to be even concerned about a difference between what is statistically significant and what is clinically significant? Like, I know that you mentioned earlier in the phase 2 trial, the reason you stopped the trial was because you were seeing statistical significance, right? In terms of the positive change in the patients, they were doing much better with the ascorbate. Can you talk a little bit about statistical significance versus clinical significance? Because I don't know that our listeners understand that. And it is kind of a interesting, or it's something that's important to consider in these studies, especially with small groups of people.
Yeah. So you kind of alluded to it earlier too, when you said a study had an increase of 3 months overall survival. Well, if it's something maybe like some tumor where you can live 10 years, like prostate cancer, you can go a long time with prostate cancer. 3 months out of 10 years is not much. So it might be statistically significant, but is it clinically significant? I don't think so. So that's kind of a that's kind of a rough way to look at that sort of thing. But I always look at it, what is the overall survival we're talking about? And if it was me, would that be significant?
I love how you put it in terms of yourself as a doctor. I think that is nice because it humanizes all these patients, that we are people and we have lives, and we're trying to, live good lives with the time that we have on this planet. So I love that you look at it and say, if it were me, would it be significant to me?
Yeah. That's why I think it's important to look at quality of life too.
Absolutely. Absolutely. Have you seen people who have, were there safety concerns with IVC? So we talked about, some people might have more benefit than others. What about, do some people do poorly? Is it a therapy that people should be concerned about embarking on?
Yes. So one thing we do in all of our patients who are enrolled in our trials, we check a blood level of a certain enzyme, and the enzyme is glucose-6-phosphate dehydrogenase. And if you're very low on that, and I think of the 200 plus patients we've enrolled, we found maybe 1 or 2 that were really low on that, we would be very hesitant to give IV vitamin C, because that enzyme detoxifies hydrogen peroxide. Indirectly, it detoxifies it. So if you're really low on it, you could get overwhelming hemolysis, or the blood cells would just kind of break apart. So we don't give it in patients that have deficiency in glucose 6-phosphate dehydrogenase.
Is that a common thing to be deficient in that?
No, it's not common at all.
Okay.
Like I said, in maybe over 200 patients we've looked at, I think we've only found 1 or 2 that had a deficiency in that.
Okay, so it's pretty rare, but it's important enough that anyone who's going to do this should be tested.
Right. And the other thing I would warn too is patients who have a tendency to get kidney stones. High dose vitamin C may predispose to getting kidney stones. Now, versus hemolysis, which could be life-threatening, kidney stones are not exactly life-threatening, but still, significant. So
yeah, and they're wicked painful. I've had one.
Yeah, exactly. And we've had some patients who, like 1 or 2, who were on IV vitamin C and they developed a kidney stone.
I see. So it possible, but again, rare. It sounds like.
Yeah.
Okay. Yeah. Rare. And, we've talked about a lot of some different cancers where you're starting to do more work. We talked about glioblastoma and non-small cell lung and colorectal. What about the 2 biggies? What about breast cancer and prostate cancer? Because that affects so many people. Do we think that it would have an effect on those cancers, or is there any reason to believe that might be beneficial?
Well, our lab has done a little bit in both of those. In breast cancer, we showed in some breast cancer cell lines that it does work. But the reason we were doing those cell lines is one of the problems with breast cancer is one of the drugs given for breast cancer, adriamycin, doxorubicin, can cause significant cardiac damage.
Yes.
And what we showed in a mouse model is that IV ascorbate actually killed the tumor cells, killed the breast cancer cells, but it reversed the cardiac damage from doxorubicin. We've never published that. We need to publish that.
Yes. I would be very interested to let people know and to, read more on that, because that is I know I have to personally get an echo every 3 months because of possible heart damage from the medicine I'm taking, which is different. I think it's either associated with trastuzumab or Perjeta. I can't remember which one. But so having something that could mitigate that heart damage, we can't live without our hearts, right?
Right. Yeah.
That would be big.
So, we've never published that. We need to do that. The other is prostate cancer. We've shown some of the mechanisms where prostate cancer metastasizes or invades. And we've shown that IV vitamin C or pharmacological ascorbate inhibits that mechanism, that process of invading and metastasizing.
So and is that like an in vitro or vivo?
Yeah, in vitro and in vivo. Yeah. Mm-hmm. Yeah. So it hasn't progressed any further than that.
Mm-hmm. So, but at least like in the lab is what we're talking about, as opposed to in humans so far. And do you have plans to develop clinical trials for either breast or prostate?
It'd be nice, but there's only 24 hours in a day.
Yes.
And what I need to do is find a junior person who that's their area of research interest and they want to go for it. So.
Well, maybe we make a plug for that, for those junior people to contact you and pitch themselves as the next generation, because there certainly are a lot of prostate and breast cancer patients who would love to have another tool in their toolbox.
Yeah. And as far as prostate cancer, I know there is one trial using IV vitamin C, and the results haven't been published yet. And it's in patients with very late stage prostate cancer. And I don't think vitamin C had much of an effect. Mm-hmm. And so what we're saying is that vitamin C seems to have an effect in some cancers, and a very positive effect. It may not be beneficial to all cancers at all stages. Mm-hmm. Okay. You know what I mean? So, if it fails in one tumor type, that doesn't necessarily mean it's going to fail in all tumor types. And if it works in one tumor type, doesn't mean it's going to work on all of them.
And that's true, I believe, where, like, for example, just breast cancer, there are many different tumor types of breast cancer, right?
Right. Mm-hmm.
So even within a tumor site, I'll call it a tumor site, such as the breast, there are several different cell lines that they know are like kind of common mutations for cancer. And so it may work more against one versus another.
Yeah, right. I mean, yeah, breast cancer, ER, PR positive or negative, triple negative breast cancers. I mean, there's a wide range of breast cancers there.
So I had read something about mutations, like specific mutations, as we're talking about cell lines and types of tumors. Let's think about even things on a smaller level and the gene expression itself. And I've read that IVC can be maybe particularly effective against specific gene mutations such as KRAS and BRAF, BRAF mutations, KRAS mutations being something that's very prevalent in pancreatic cancer. My understanding is like 90 to 95% of those cancers have that mutation. Right. Have you found that results track with a specific mutation? Have you tested for that? Or do you see it as being a benefit that's universal beyond those specific mutations?
Yeah, so it's a great question because one of our, I wouldn't say competitors, but one person on the East Coast that now lives in Boston, but I won't say his name, proposed that these BRAF and KRAS mutations is why vitamin C worked. And we showed quite convincingly that's not the case. We took mutant KRAS, tumor cells that had mutant KRAS or mutated KRAS, and we took tumor cells that didn't have it, and they both responded the same way.
Really? That's interesting. Sometimes, I'm just going to tell the listeners, the cells that do not have a mutation might be called wild type.
Yeah.
Is that right? So if you read a piece of research, you might see KRAS mutated versus KRAS wild type. And I was confused for a long time, but then I saw that wild type actually just means it's not mutated, right?
Right, exactly, yeah.
One of the things we've talked about throughout this conversation is the mechanisms of action. And I wanted to probe something in particular because I had done a bunch of reading on this, and that has to do with ferritin levels. So I've read that a lot of cancer patients tend to have very high ferritin levels, and that is associated with iron, or a measure of iron, I believe, in our bodies, and that IVC works by binding with the ferritin, and then that reaction by donating an oxygen molecule, then it creates the hydrogen peroxide. Help me understand ferritin and how that plays a role.
Yeah, so ferritin is like we did this with manganese too. There's compounds out there, they're called porphyrins, and we combine them with ascorbate. And ascorbate alone will make the hydrogen peroxide. But when you give it with a redox active compound like ferritin or manganese or something like that, it makes industrial strength doses of peroxide. And so that's what's happening. So it kind of catalyzes the reaction and makes more of it, which is great to kill the tumor cell. But sometimes you got to be careful too, because you could give too much. But that's kind of the mechanism of action.
So personally, I'm going to just make this about me for a second. My ferritin levels are low, actually, and maybe they weren't always, but I know that currently they're low, and I currently have no evidence of disease. So maybe those two things go together. Well, I'm not sure, but I do know that currently my levels of ferritin are on the low side. So do you think it would still work? Would ascorbate acid still work as a anti-cancer strategy if you have low levels of ferritin?
Yeah, it will. It would. Yeah, we my colleagues here at Iowa who are looking at glioblastoma, they looked at ferritin levels, and it has to do really with the iron, the free iron that's near the tumor cell. So you have serum ferritin that may be low, but you don't know what the iron levels are in the tumor cells. If it's high, then it probably would work. The ascorbate would work better. But it's just I would say it's a snapshot, or it's an indirect way of looking at things. Mm-hmm. It might be important, but I don't think it's necessarily important in every tumor.
Mm-hmm. Interesting. Are there any other things that you're looking at combining with ascorbate to provide synergy or increased efficacy that we haven't talked about yet?
Well, along with the iron thing, colleagues of mine that look at glioblastoma are looking at ferromoxitol, which is a compound that increases iron in tumors, and they can image it. And what they found in a few patients, they've done this with glioblastoma, that they're getting better responses than with ascorbate alone.
Interesting.
Yeah.
Interesting. Yeah, one of the premises that I have in the research that I've done is that, because there are so many different pathways that cancer uses, and it's such a complex disease, that layering strategies can sometimes be beneficial, whether that's adding exercise in or adding, calorie restriction or things like that. But you kind of, as we start to understand the mechanisms of actions of these things, you can start to see where there are opportunities of synergy. And I think I see hope in that.
Mm-hmm. Yeah. And that's, when you mention that, that's one of the areas that the most medical oncologists don't get. They think that if we give IV ascorbate, they think it's an antioxidant and it's going to reverse the effects of chemotherapy. And at oral doses, it might, but not at these high doses. It's not going to.
So let's talk about that for a second. Is oral doses of vitamin C a help when you have cancer, or is that something that maybe cancer patients should avoid, or do we just not know?
I would say we just don't know. But I would also say that there's some good evidence in patients who have bladder cancer that mega doses of oral vitamin C might be beneficial. And why is that? It's because when you get a certain level, the body will excrete it in the urine. And you can get up to 5 to 6 millimolar levels in your urine if you take mega doses of oral vitamin C. So it's anecdotal, but there's some not very good studies to show that in patients that have superficial bladder cancers where they're followed, if you give themselves oral vitamin C, it may reduce the recurrence of those superficial cancers.
That's really interesting. It makes logical sense. I get it makes very, even if we don't have all of the studies, there is some logic there of if it's going to go sit in the bladder, then and it's waiting to be excreted, then you're sitting with this amount of high dose vitamin C that isn't getting to the rest of the body, wouldn't help you with a glioblastoma, but could help you in that one organ.
Yeah. Mm-hmm.
Do you see a pattern with how far cancer has spread and the efficacy that you're seeing in your studies?
We haven't looked at that directly, but I would just say it probably does. Mm-hmm. We've enrolled, because this is a randomized trial, we didn't want to bias anything. Even patients who were really sick and we knew they weren't going to do very well, they got randomized to get ascorbate, and lo and behold, they didn't do very well. But we wanted to keep it kind of, we didn't want to pick and choose.
Yep.
As far as number of metastases and where, I don't think we haven't analyzed that, and I'm not sure we've seen any trends in that area.
Mm-hmm. Mm-hmm. So. Okay. Well, I just want to wrap up with talking a little bit about the future, if there are future plans within your organization or any upcoming trials that you know of or that you are going to be doing that you want to direct patients to. I just want to give you an opportunity to talk about the future.
Oh, okay. Yeah. Well, the future, I think if we get some of these trials published, I think it's only going to get brighter. The number When we started doing these studies with vitamin C, there was only one medical oncologist that had the guts enough to give it to patients. Now, every patient who walks in the door, the medical oncologists want to give them vitamin C. And some people that have been here at Iowa for a while and then gone elsewhere have started their own trials, which I think is great. As far as future trials, we're in discussion. Our group is in discussion about what we want to do with kind of the limited resources that we have. So that's kind of still ongoing. I think glioblastoma and pancreas, we've seen some really good results. And I think we'll continue in those areas.
That's exciting. I know those patients definitely need some new treatments and some champions. So I think that's great news. And then finally, I'm hoping you can just summarize the key points from today for every patient. What should every cancer patient know regarding IVC?
First, that if you give oral ascorbate, you don't attain the levels that you do when you give it intravenously. And when you give it intravenously, you increase the levels 500-fold. And at those levels, it kills the cancer cells. The best way to give it is probably 3 times a week. We've never found a chemotherapy where it reverses or inhibits the work of the chemotherapy. It synergizes with radiation and some chemotherapies. Our results have been very step-by-step wise, and we have the mechanism of why this works and how this works, unlike other type of complementary alternative medicine practices. We're seeing some good results, so we got to keep plugging away.
Yes, I agree. We'll keep on our end trying to continue the dialogue and getting people interested in asking for it, because I think patient pressure can also help the medical field push forward in some of these things that have promise. So lending our voices to that and saying that it's important may help with research funding, I hope.
Yes, yeah. I think it already has, because we've had anecdotal reports that some Congress people have talked to leaders at NIH and say, why aren't you doing anything about this? And they point to our studies saying, well, we are doing something about it. So
awesome.
So I think that helps.
That's great. Well, thank you so much for coming today. Again, we really appreciate your time. This has been wonderful, great information. And yes, thank you.
Yeah, you're welcome. It was fun.
And now an important announcement. All the information that was provided today was for educational purposes only. I'm a patient, just like you. I am not a licensed or accredited physician, therapist, or clinical researcher. All information provided is not intended as a substitute for the advice of a physician, therapist, nutritionist, or any other qualified healthcare professional.